Welcome, everyone. I'm Dr. Carmen Puliafito, and I'm happy to welcome to Retina Synthesis today Dr. Susanna Park, who is Professor of Ophthalmology at the University of California, Davis, where she holds the Roth Endowed Chair in Visual Science. Dr. Park, welcome to Retina Synthesis.
Thank you for inviting me, Carmen. It's a pleasure to connect with you to discuss an important topic that you proposed.
Yeah, so today we're going to talk about the past, present, and future of venous occlusive disease, retinal venous occlusive disease, with an emphasis on central vein occlusion. But I thought that we would start off by just getting an overall perspective from you about where this field is going, where it's been, where it's going.
Well, as you all know, retinal vein occlusion is the second most common retinal vascular cause of vision loss, especially in the elderly. And it's second only to diabetic retinopathy. We currently have, fortunately, many treatments to treat the complications of vein occlusion, such as macular edema or neovascularization, which can also add to the vision loss. However, many patients with retinal vein occlusion continue to have vision loss, even with all the treatments we currently have available. And so I think the future direction for treatment of retinal vein occlusion is regenerative therapy, finding ways to repair the actual damaged retinal vasculature and repair or regenerate some of the retinal neurons that may have been damaged by retinal ischemia. So that's an area of research I'm actually exploring at the current time.
Yeah, we really like to talk about that. But just to talk about some more basic issues, what about branch vein occlusion these days? What are we doing about treating the complications of branch vein occlusion?
Okay, so when I see a patient with branch retinal vein occlusion coming in with vision loss in my clinic, the first thing I do is, check the vision, do a complete exam, and do OCT to look for macular edema. If the patient has macular edema with vision loss of 20, 40 or worse, my first line of treatment is to initiate intravitreal anti-VEGF therapy. I also look for signs of retinal ischemia and neovascularization and follow these patients, especially if they're off anti-VEGF therapy, to look for evidence of retinal neovascularization that might warrant scatter laser photocoagulation to minimize vision loss from complications of such as vitreous hemorrhage. So, currently we have 3 anti-VEGF therapies we can use or offer for these patients. We have bevacizumab we've used since 2005, which is off-label. Sometimes the anti-VEGF therapy we choose, for me, is often limited by the insurance. Sometimes they tell us to use bevacizumab because it's cheaper. So that's an option for our patients, and it's warranted based on SCORE 2 and LEVO study, which did not show a big difference among the anti-VEGF therapies. We also have ranibizumab, which we've used for a long time, and it's on label, as well as aflibercept. So in general, for my patients as first line, I offer them bevacizumab or ranibizumab, mainly because ranibizumab doesn't linger in the systemic circulation. And we have a long history of use showing efficacy and safety. And I inject these medicines monthly until we get maximum resolution of the macular edema and improvement in vision. And then I propose a treat and extend approach to try to minimize the number of visits and injections for our patients. If the macular edema doesn't fully resolve with anti-VEGF therapies, bevacizumab or ranibizumab, I do consider switching to aflibercept because based on my own personal experience, I do think the aflibercept can be a little more effective and longer lasting in some of the patients. So I try switching to aflibercept. And if the macular edema doesn't improve, even with aflibercept, or I cannot extend the interval very much, then I offer grid laser treatment. And I've actually tried combining grid laser treatment with anti-VEGF therapy with some success in terms of resolution of macular edema and extension of treatment interval. The other treatment option to offer is intravitreal steroid if the patient doesn't have glaucoma or risk of cataract progression. And so, usually I use triessence if it's available, but currently we have a shortage of triessence nationally. So we can use triessence if it's available, 1 milligram usually. And if the patient has an intact posterior capsule, I can also offer intravitreal dexamethasone implant. So that's how I would treat my patients currently with branch retinal vein occlusion.
That's a wonderful treatment paradigm. What about how often is it possible for you to stop treating patients with vein occlusion?
I would say, I do stretch them out, and usually if it's about, we can stretch them out to about 12 weeks or 16 weeks. I often give them the option to stop their treatment and see how they're doing. And I would say a good 20 to 30% of patients over time may not need ongoing treatment, but the majority seem to require ongoing treatment of some sort.
Right.
Yeah.
What about NVE? How do you manage that?
If there's evidence of NV, especially if there's vitreous hemorrhage, then I would go perform scatter laser photocoagulation, especially as we extend the anti-VEGF interval. If the NVs might pop up and cause vitreous hemorrhage. And so I propose doing laser treatment to the ischemic retina.
So what about central vein occlusion?
So central retinal vein occlusion, I have a similar, treatment plan for central retinal vein occlusion. The studies have not shown a big benefit of grid laser treatment. So I don't offer grid laser treatment for those patients alone or in combination with anti-VEGF. But similarly, I basically look for evidence of macular edema at presentation and offer intravitreal anti-VEGF therapy as first line. I don't typically perform fluorescein angiography at presentation just because there tends to be a lot of retinal hemorrhages and you get limited information. However, if they're not on regular anti-VEGF therapy, I will see them monthly to look for evidence of iris neovascularization so that I can do prophylactic laser treatment should they get iris neovascularization as recommended by the central retinal vein occlusion study. So, and again, look for risk factors associated that the patient might have for central retinal vein occlusion, such as their age, hypertension, diabetes, hyperlipidemia, glaucoma, smoking. If the patient is young and doesn't have any of these risk factors, again, I would do a systemic workup to make sure that they don't have a hypocoagulable state that might be causing the vein occlusion.
And treating macular edema.
Yes, and treat the macular edema with intravitreal anti-VEGF. And similarly, I would start with bevacizumab or ranibizumab, depending on whether the patient wants on-label or treatment. And then if I don't get full response, so I can't treat and extend very much, then I could switch to aflibercept. And then once again, if there's a small percentage, I'd say about 10% of patients with macular edema from retinal vein occlusion that don't always respond readily to anti-VEGF. And in those patients, I would offer intravitreal steroids and inform them of the risk of glaucoma and cataracts as we make the conversion.
Yeah. Do you think the incidence of neovascular glaucoma is decreasing in eyes with central vein occlusion, or is it about the same?
Decreasing in eyes with central retinal vein occlusion.
Now that we're in the anti-VEGF era.
Yes, I think if the patient is maintained on anti-VEGF therapy, less than every 8 weeks, I don't worry about neovascularization as much because the anti-VEGF therapy will take care of that. It's when you extend the interval or discontinue anti-VEGF therapy where you may start to see neovascularization. So, even if they're off anti-VEGF therapy, I do see them at a regular interval just to make sure the macular edema doesn't come back and the patient doesn't get neovascularization.
So do you do a treat and extend model there as well?
Yes, I do use a treat and extend model for all my anti-VEGF therapy patients.
And what's your longest interval that you can manage patients? 12 weeks?
At 12 weeks, before COVID, if we extend to 12 weeks and the patients were fine, I used to give them PRN, convert them to PRN,
Mm-hmm.
see how far they can go before they have another recurrence. With the COVID, because the patients don't want to keep coming in for PRN injections, I just keep treating and extending. So I have patients who come see me every 6 months for an injection as we kept treating and extending. And some of these patients we can probably stop, but then if I stop, I have to see them more frequently. So
Mm-hmm.
people have, I've just kept extending, at least during the COVID period.
So COVID inspired a change in your treatment algorithm.
Yes, that's the way it has, I tried to minimize the number of trips that the patients make to my clinic. And the patients seem to appreciate that. I do give them the option of coming to see me every 4 to 6 weeks for PRN injection versus treating and extending where they may not have to come and see me for a few months. And they usually go with the treat and extend.
Well, central vein is certainly a chronic condition.
Yes. For the majority of patients.
And that makes it challenging for the patients and the treating physicians.
Yes.
Patients want to know, when is this going to end? And the answer never is not well accepted.
Never well accepted. But, I do tell people that people on anti-VEGF, if you follow them long term, the mean number of injections tend to go down for on the average. But there are some people who need more injections over time, and some people who need fewer injections. So it's hard to predict, but they need to be monitored regularly for a long time.
So we've talked about the past and the present. What about the future?
So the future is, as I mentioned, we're doing research on regenerative therapies, cellular therapy. And, the idea is to basically not only treat the complications of retinal vein occlusion, but to treat the underlying pathology that causes vision loss, which is, retinal vascular damage leading to retinal ischemia. And so, I've been personally very interested in exploring CD34 positive stem cells that we have in our bone marrow. And the reason I have interest in these cells is because it's been known now for over 2 decades that they are natural repair cells in our body. So if you have some sort of tissue damage somewhere in your body, there are signals transmitted through your bloodstream that mobilizes CD34 stem cells in your bone marrow into the circulation. And these cells home into the damaged tissue where they engraft and secrete factors to promote repair. Now, because CD34 cells also include endothelial progenitor cells, a lot of studies have explored the use of these cells for retinal vascular disease or ischemic disease, where the cells can engraft into the damaged vessels and promote repair. But theoretically, these cells can actually be used for any kind of tissue damage because they also contain hematopoietic stem cells that we've used for bone marrow transplantation for many decades. And these hematopoietic stem cells have been found to be the main paracrine secreting cells. So these are the stem cells that actually, when they see damaged tissue, secrete factors that promote tissue repair. And the cells don't seem to be limited to any particular tissue or damage type. So potentially they can be used, there could be a broad clinical application of these cells. And I personally got the idea of exploring these stem cells because I heard about a cardiology clinical trial that was ongoing about 15 years ago, where people who were going through angioplasty would actually get CD34 stem cells from the bone marrow, and then it would be infused into their coronary artery to promote, minimize the damage to the cardiac myocytes. And there is phase 2 clinical trial evidence showing that there is benefit of such a therapy. But you have to be very careful about the cells you select because bone marrow has a lot of cells. And when people try to treat patients with crude mixtures, it wasn't shown to be as effective. So in our study, we basically done preclinical animal studies showing that we and others have shown that if you take human CD34 cells and inject them into the vitreous, within days, it rapidly homes into the damaged retinal vasculature. If you use an animal model of diabetic retinopathy or retinal ischemia, they home rapidly into the retinal vasculature. And we've done long-term studies showing that these human cells can be found 6 months later after a single injection, still incorporated into the retinal vasculature, showing long-term incorporation of these cells. Now, these studies, of course, were done in immune deficient mice because, human cells into mice, the cells are going to be rejected. So in our immune deficient mice studies, we've also shown that intravitreal injection of these cells results in preservation of the retinal vasculature long term. So without any adverse effects in the eye or systemically. And so based on those results, we were able to get an investigational new drug clearance from the Food and Drug Administration to initiate a clinical trial to see if such a therapy, autologous cell therapy, where you get your own CD34 cells from bone marrow and inject it into the vitreous, whether that could be feasible and well tolerated and potentially of benefit in patients with vision loss from retinal diseases. And so we published the paper several years ago in IOVS, summarizing the results of the first 6 patients we treated with autologous intravitreal injection of autologous CD34 cells. And we showed that this cell therapy was feasible and well tolerated in all the patients. It was an open label study and some of the patients actually could see better, but we couldn't tell whether it was the stem cell effect or placebo effect because everybody knew they were getting a novel treatment. However, the patient we had with central retinal vein occlusion, you could actually see changes on fundus exam and fluorescein angiography, and the visual gains seemed to be the most dramatic. So we selected central retinal vein occlusion to be the first condition we wanted to explore in a larger clinical trial. And we were successful in getting funding support from the National Eye Institute to conduct the TRUST study. And the TRUST study stands for Treatment of Retinal Vein Occlusion Using Stem Cells. So this is an ongoing phase 1-2 study. We're still enrolling. It's a randomized sham-controlled double-masked study of patients with vision loss from central retinal vein occlusion. And we are enrolling patients with a visual acuity of 20/40 to 20/400. And this is visual acuity after you exhausted all available therapies, including intravitreal anti-VEGF therapy. If this is the vision range you have, we consider enrolling you for the study. Basically, the study is a 1-year study, and you're randomized 1-to-1 to either sham treatment at the beginning with stem cell treatment at month 6, or stem cell treatment at the beginning with sham treatment at month 6. And so everybody who's enrolled will eventually get the stem cell treatment. Our goal is to enroll 20 patients. We do have a very extensive inclusion-exclusion criteria. So the enrollment, especially with COVID, has been a little slower. It's been picking up now that COVID's a little under control. Our goal is to finish enrollment by the end of the year. As a masked investigator, I can't give you more information about that except to say that we have a data safety monitoring committee overseeing the study consisting of experts in hematology, ethics, retinal imaging, and biostatistics, and they review our data at a regular interval. And so far, they've given us the green light to continue the study because they haven't seen any major safety concerns.
No, that's exciting.
Yes.
So does the repair occur on the arterial or venous side of the circulation, or both?
So, basically it homes into the damaged tissue. So, we've done studies in diabetic retinopathy and ischemia reperfusion injury. So basically, if the tissue is not damaged, the cells don't do anything. They just go back to the bone marrow. And so depending on the model, if it's capillary damage, it will home into the capillaries. If it's venous damage, it will theoretically home into the venous retinal veins. And so, basically, I don't think we have a perfect model of retinal vein occlusion in animals. So, in the animal studies, we've seen preservation of the capillaries in eyes with diabetic retinopathy. And then in the ischemia reperfusion model, we did see incorporation in both vessels, but, it depends on the model of vascular damage that you use. It's hard to see the homing of the vein, the stem cells into the vessels in live patients, because we don't have imaging modality that's sensitive enough right now to do that.
Is harvesting the stem cells relatively straightforward?
Yes, I mean, I don't do it. It's done by a hematologist.
Well, I understand that.
And it's actually done with the patient awake with just minor sedation and local anesthesia. And, I was worried that it might discourage patients from continuing in the study, but, there are several patients that want to go through it again to see if the vision improves any further, so it's minor discomfort. We watch them closely. Nobody has had walking problems after the procedures or bruising. So it's been pretty well tolerated. And we've gotten pretty consistent, as far as I can tell from the study team. We seem to have pretty good yield of the patients who've had the bone marrow aspiration. So we'll see. Once it's all unmasked and I have access to all the data, I can give you more information. But so far, that's what I've heard through the grapevine.
Well, this is really the most exciting new development in the treatment of vein occlusion, because really we've been chasing complications with anti-VEGF agents very successfully for the last 15 years.
Yes.
But as we said, this is a chronic disease. So regenerative medicine is an exciting approach.
Yes. And so with any kind of novel therapy, we've limited the enrollment just to make sure there aren't any major safety concerns. I know there are other cellular therapies that are being explored mainly for retinal degeneration. And we are exploring CD34 cells for retinal degeneration as well. I think the advantage of CD34 cells are that you can use your own cells, so you don't have to worry about immune rejection of the cells. And the cells are not cultured. You get them fresh from bone marrow and inject them into the eye. In fact, if you try to culture them and expand them, you cannot. They don't readily grow. And so that's a favorable thing from a safety standpoint, because one of the adverse effects you worry about with cellular therapy is abnormal proliferation of the cells in the eye, which has been observed in some cellular therapy clinical trials. And so far we haven't observed that. And I think with these cells, the risk of that is very low. So.
Well, congratulations on your efforts in getting this underway. Really, it's amazing.
Well, it's a newer approach to treating vision loss from retinal problems. And I think the idea that you can use your own stem cells and the cells could work with different retinal diseases is exciting to me, just because we have so many retinal conditions and associated vision loss that we cannot treat effectively even today.
Well, we anxiously await the results, which will be coming sometime in 23 or 24.
Probably. It's probably going to be at least another year and a half before we
Yeah, well, that'd be great. So thanks a lot for your participation in retina synthesis. And I know our audience will be really interested in hearing about this.
Yes. And, for the retinal specialists and ophthalmologists in the audience who treat patients with central retinal vein occlusion, if you have any interest in enrolling or referring patients for the study, please contact me. My email is sscpark@ucdavis.edu. Thank you very much.
Thank you.
Yes.
Thank you.